Good morning to all of you. We welcome you all for this month clinical meeting. It is going to be from the Department of Neurology and Neurosurgery. The first talk is going to be from Dr. Vedhanayagam, Footsteps of the Brain When Walking Speaks. Now, it just reminds us olden, the medicine days, wherein our professors used to ask, when a patient comes in, you just handshake it, so you can win the confidence of the patient. You can diagnose certain neurological diseases like myotonia and endocrine disease like hyperthyroidism. So I guess that he is going to talk on gait. So itself is a book, very interesting talk. We are awaiting to listen to you. Over to you.
Good morning to all. Thank you, sir. So actually, neurology is a clinical medicine, so where you can diagnose even the patient arrives to you. So my theme is to understand the gait pattern, at least to find out the lesions according to the gait. So if you see the gait, you can able to localize the lesion. Actually, it is a masala talk. I will have patient videos, 5 to 6 patient videos, followed by our consultant videos for a better understanding of the gait and the gait patterns. So thanks for the all. And aim is to localize the structure and to recognize the pattern of gait. So this is a complex neurological circuit for the gait initiation, maintenance, composure, and for the maintaining the posture. So you can see from the downwards, you can able to see the spinal cord. So here where is the locomotor center, that is means it is a generator center. It is automatically it generates a locomotion. That means it's makes the legs to flex and extends according to the need. So it means the locomotor center, it is automatic center in the spinal cord at the lumbosacral region. It initiates the gait. Actually controls and initiates the gait automatically without any external stimuli. Then it is followed by the pons and medulla. In the midbrain we have a midbrain mesencephalic locomotor nucleus, and the pons we have pedunculopontine nucleus. Both have the gait initiation and control over the spinal cord. Whenever you want to stop the gait, it will give a input to here. So these are the these are the centers. Another things you can able to see the cerebellum here. It is controls and coordinates. And next thing is the basal ganglia. It gives inputs and fine tuning. And the main thing is the motor command from the frontal and parietal lobes, where the motor planning is happening in the subliminary motor area, and the gait is initiated by the motor cortex. In the same way, it gets information from the parieto-occipital cortex, where it initiates, maintains postures during the gait. So I have told about the 6 common structures for maintaining the gait. At the spinal level, central pattern generator, as like we are doing swimming and swallowing and for breathing, it create automatic center. It is as like swimming, we have a center in the gait at the spinal cord level, that is at the lower lumbar level. And the brainstem I already told, then the cerebellum and the basal ganglia, motor cortex, sensory inputs. So these are the common structures for maintaining the gait. So if there is any problem here, we will have a problems. Then that is a unique pattern of gait will be altered. So same thing. So while walking, we should not fall. So we need signals from visual, vestibular, auditory, proprioception, touch, and visual. These are the symptoms. And if someone calls while walking, we have to stop. That time it needs cognitive process. So everything happens in a complex manner to able to walk. So again, the summary, the cortex plans the movements, the basal ganglia and the cerebellum refine the movements, and the brainstem sends commands to the spinal cord, and the sensory feedback, our pattern is maintained. So we are dividing the gait problems into higher level, mid level, and lower level. The cortex and subcortex are higher level gait disorders, and the basal ganglia, thalamus, cerebellum, brainstem up to the peripheral nerve, it is mid level gait disorders. That means cortex is the higher level, and the below subcortical nucleus is and all middle level, and the lower levels are peripheral nerve, neuromuscular junction, and the orthopedics. So these are the common disorders. In neurology, at least we must know these type of gait to understand about the gait nature, and purpose of this slide is to understand these type of gaits to easily identify during the exams. So this is the first video I am showing to you. So you can watch. This patient is having initiation difficulty. Legs are tracking, little bit circumflexion, but you can also notice the dystonic hands. So again I will put it for you. You can clearly say it is not a circumflexion gait, but you can say dystonic circumflexion gait. This is sir broad base. He has a vascular Parkinson also, sir. Broad base. And the gait description, we have to do some basic manners like how is his posture, stance, and what is the cadence and speed, how he is walking. These are the parameters we have to explain. This is a lesion for that patient. This patient is having thalamocapsular ganglionic bleed. So that's why he has a left upper and lower limb weakness. And this is the next level. The higher level, one is subcortex, and the next is Parkinson gait. You can able to understand this type of tremor very well. And here initiation difficulty even after asking to walk. Whilst touching he walks. With the sensory cue he can able to initiate the gait. And you can see the legs. It is shuffling. That means short steps. It is not clear the grounds. It is attached to the grounds. So this is called a shuffling gait. And also while turning he makes so much difficulty. And you can also notice the camptocormia, that is the forward stooping of the spine. So this is the next level. And this is a mechanism while the patient is having freezing and fall and rigidity, everything is in this slides. It is difficult to understand, but we can leave it. And this is next level. And this is, it's again, you can able to understand it is ataxia gait. So wide base and truncal ataxia is more predominant than the lower limbs. That's why this patient has a truncal motion. Without his help, without her help, see, he will fall. As like it is drunken gait, but it is not as classical in the descriptions. So ataxia gait. So this is a lesion for that patient. He has a multiple lesions, so all over the areas where I have shown in the pictures, the cerebellum, cortex, subcortex, everywhere, the brainstem, even the nucleus also has a problem here. So that's why the patient has a dearranged gait. And this is next level gait. You can understand that is a scissoring. I usually it is seen in the cerebral palsy, but in adult you have in the lesions. So you can able to see that is a circumflexion of the both legs simultaneously. This leg is going like this, and this is scissors in between them. So scissoring gait, and the lesion is here. The lesion is here. It is a traumatic compressive myelopathy causing scissoring gait. So next this a lower level. I am going to the lower level. This is that video. So you can able to recognize the right leg is drop. It's like foot drop, and the thighs are goes up in order to clear the ground. So it is a high steppage gait. Little bit this leg also has some weakness. It is a CIDP. So kappa gamma globulinemia positive CIDP. So where the patient has high steppage gait. So this is lower level. So from cortex to peripheral now we have the lesions, and we have a different gait patterns. Okay. It is taken from the YouTube. So where the one person having all sort of gait problems, we are going to see him. So each gait I will explain to you. It is a YouTube disclaimer. It is a Trendelenburg gait. You can observe him. And this gait I don't know. And this also some unique pattern. This is cautious gait or senile gait, but he is very young. doing senile gait. And this also I don't know what type of gait I did. But he has jerking while walking. Maybe taken it as a style. Also doing some, and this is little bit marching. He is going to have some neurological disorder. And this is again ataxic trunk. And this is actually camptokarmic. This is very cautious gait. Little bit the lower level gait disorder, I think so, because he is walking very little bit odd. This is excess kyphoscoliosis. The straight spine. You can see the limping. It is ortho problem. Mohan sir will explain. And again, there is a double ortho problem. Both Mohan sir and Google sir will tackle. And this is going to have some illicit something he is doing. And this is also little bit very hard. While walking, he is shaking his head. And this is real marching. And again the Trendelenburg comes again. Bilateral Trendelenburg. I think this is normal gait, as our consultant is doing walking. And this is little bit odd, some little bit hemiparesis he has. This is also normal gait I can take with some respect, as like me he is doing respect to all. He is a warrior. Actually cautious and senile gait. This is stylish. He's singing song also. While walking, we are doing lot of works, so cortex should be intact. So why should we celebrate our unsung heroes? Why should not we celebrate our unsung heroes? That's why I have taken our consultants' videos for you. Before that, I will put the disclaimer: unsung heroes of SRH. Don't file a case on me. I am already have one court case. Dr. Rajagopal sir and Alagapan sir is helping for us. And tributes to thanks and for our heroes. And sorry for the other whom I missed unintentionally. Let us have a walk. Yes, start with Chief, who is giving a lot of என்ன சொல்கிறது நிறைய கற்றுக் கொடுத்துருக்காரு. So it is tribute to him. He is teaching still. He is one of the teacher. He always teaches us. I am a student of him. We used to go to the GH for getting his class. The next video, it is very interesting. He's a friendly manner. He will எல்லாத்தையும் கலாச்சிருவார். அவருக்கு ஒரு கலாய்ப்பு போடலான்னு போட்டோம், பட் பிரச்சனை ஆடுன்னு சொல்லிட்டு இப்படி பண்ணோம். ஆக்சுவலி ஹி ஃபைண்ட் இட் அவுட். வீடியோ எடுக்கிறத பார்த்து கண்டுபிடிச்சிட்டாரு. ஹி ஹாஸ் a unique pattern. அடுத்த வீடியோ இவர் நம்ம சாரு எங்கே போனாலும் இப்படி தான் போகிறாரு. பழைய மோகன் மாதிரி தான். But he has a stylish walk. பேஷண்ட் தேடுறாரு, இன்னும் ஸ்டாஃப் யாரும் கூட வரல. நெக்ஸ்ட் வீடியோ யார் வேணும் உங்களுக்கு? ஸோ திஸ் இஸ் அவர் சூப்பர் ஸ்டார். He intentionally wants Rajini songs. Madhusankar. While taking video, he explained to me, so you should give a good video. I will walk twice அப்படின்ட்டு. I think he is okay with this song. I think so. Good. And this is our Dayal. is given to the all sort of doctors and all time. And he's joined in some party. If there is any problem outside, he will help you. So that's why I put this song. He has a unique pattern of gait. You can watch his left leg is deviated to left side. As because of his weight, I think so. The next is I am going there, but don't follow me. I have a separate video. This is our again the superstar. Yes, our sir only. He always comes with crowd. Without crowd, you can't see him. I will put it again because it is light is not so much of it. He also find it out. Oh, why are you taking video? The next video, I think it is not boring you, right? So it is for our madam. Actually, வேற song select பண்ணோம், but it's okay. It's a normal gait. Madam, எதுவும் சொல்லக்கூடாது நீங்க. This is our PG. He always works in the ward, always works with all consultants, and he puts notes even to the nephro patients. That like he is working very hard-working fellow, but I don't know. Among all these videos, I like this gait and the videos very much. Most suitable videos. I don't know what he is going to do. Even nephro patient is putting notes. We are doing neurology work. And this is my PG. He is having only 4 IP cases, but he walks like jet, but not seeing patient. Only going and coming back. So notes I have to put. That is the problem. And this is our Sridhar Gopal. He asked so many questions before taking videos. So he asked blood samples. So Sridhar, it is a video. It is not given for the results. So he is actually fighting with Deluxe C and coming for the videos. So and talking the staff. He's scolding the staff like anything. Why the reports are not coming? Sister says, just now the blood has taken abdin. So he, even without without owning the camera, he is coming out. So again, I will do 2 times a video. It is Sivakarthikeyan song he wants. And this is our always young Maddie. Actually, he wants this video in a separate room. That is a Deluxe A. So no resistance, no hindrance, everything was there. This is a video. And I think this is our Krishna. He is like a teacher. He wants some steps. He wants to do some steps also. And finally he will do like this. You can see the headpiece goes like this and he is doing like this. He wants Vijay songs, that's why I put him. So all this next எனக்கு நானே வச்சுக்கிட்டேன், ஏன்னா நான் தான் எல்லாம் பண்ணுறேன். கண்டிப்பாக பார்த்துருங்க. சரி, இது எனக்கு தெரியாமல் எடுத்துட்டாங்க. ஓகே சார், ஜஸ்ட் ஐ stop. So which video you likes more, you can comment us, we can give that video. And any video you want to see it again, that also we can do it. So one more, if time permits, I will finish within 2 minutes, sir. One puzzle for the students. So our aim is to localize the lesion. So now our PGs and medicine PGs can answer. See, this is Rajini is not a patient, that lady is a patient. So you can see where is the lesion. Any PGs? Sir, localize. I will give a clue. அட பேசுங்க, ஏதோ ஒன்று பேசுங்க. Okay. Why is his fingers are pointing like this? Any stroke patients having pointing fingers? So, okay, extra more video for you. Manoj, any comment? So I will give a clue. So these are the structures. Where you will localize? The cortex or capsule or upper motor, the medullary pyramid, spinal tract or index finger, pointing finger. Where you localize? So one more clue. Anything else? One more clue. Anybody can? See his pointing finger. Sorry, I will finish with this video. It gives a clue. So after talking with Rajini, now hemiplegia recovered. Even our sir is not treating her. Now she opened. She cries. The facial weakness are not there. Now you can see she is able to stand up. Now the legs are moving. So how does a hemiplegia patient can walk within a day? So within a minute after hearing Rajini's voice. Now she is going to talk. So where is the lesion? Now she is talking. So very hard video. It is a fake. It is a functional hemiplegia. ஸோ அந்த ஃபிலிமில் நம்மளை ஏமாற்றிருக்காங்க அவங்க, படம் ஃபுல்லாக ஏமாற்றிருக்காங்க நம்மளை. ஸோ ஸ்ட்ரக்சர்ஸ் இன்வால்வ் ஆர் capsule, internal capsule. The pointing index indicates median nerve injury. This fake videos, it doesn't have that awareness. That's why he is like put her fingers like. Usually hemiplegic patients will have cortical hand. Okay, thank you for all, and I enjoyed that presentation. Thank you for all. These are the workers behind our videos. Kavita, Usha, Asa, Sugita, Veda. Yes, it's me and the Manoj. Thank you for all. Thank you. I feel I have given some scientific content along with some entertaining videos. Thank you. Sir? No sir, no sir.
No, he is not practicing.
We have our own Rajini sir. We will treat with him.
Thank you, Vedhanayagam. I think Sridhar has reached, I don't know whether he has seen your video. You started in anatomy, ended, walked through the physiology and the clinical classes, medicine, neurology, and the SRH. And also you touched the politics. The word 3 letters BRO is quite popular now,
Yes, sir.
You call somebody's bro, and it led to all issues. So we said, where is the lesion, what is the lesion, and how to localize it. It's an entertaining one, and thank you a lot. Any questions?
மாட்டிட்டேன்னு நினைக்கிறேன்.
Excellent videos. We enjoyed. Only thing, 2 things I want to stress. So, other gait is called Geoghegan-Galton.
Yes sir.
Geoghegan-Galton means the patient walks with the short steps, and he takes every step as though some 100 kilos of weight hanging down the foot. With great difficulty, takes one step, then another step, touching the floor, scratching the floor. Slow gait. That's called Geoghegan-Galton. This occurs in frontal lobe tumors. Geoghegan-Galton. Sure. So he feels as though the foot is glued to the floor. The another thing is, you are told already, aesthesia, abasia. Aesthesia, abasia means the psychogenic gait. Thing is, the patient walks with the staggering, like a cerebral ataxia or what it may be. Or as he walks, rather, as walking, goes and holds the objects on the right side, left side, but he doesn't fall. Even if you push him down, he goes forward but doesn't fall. He manages to stand erect. Unlike, suppose if it's a real gait disorder, if you push the patient laterally, if you put him off, he'll fall to the ground. But astasia, abasia, lots of ataxia, but patient never falls. That is psychogenic.
Yes, sir. Psychogenic.
Psychogenic. And another thing is this one. Foot drop and
High step.
Posterior column. In foot drop, as you take the step, the toes touch the ground first on foot drop. But in posterior column lesion, heel touches the floor first. That's the difference. So here the toes touch the ground, here the heel touches the ground in posterior column. That's it. Otherwise, fantastic.
Nice, sir. Sir, only one video I missed it during the scrolling. That is our James Bond, Ramakrishna James Bond. So you can see him, sir. So whenever there is a big problem, he will come. So no song has been selected for him. He is the real James Bond. Actually, we don't have any song for him. It is a second time I put it because I like this video more. Thank you, sir. Thank you.
Observe other things. Now you observe, if you put a vertical, dissection on both sides, both will be equal.
Oh.
Because, so majority
No. See, it's not, including myself, not degrading anyone. As you are walking, if you put the hand back, you are getting old.
இது யாரும் நடக்க மாட்டாங்கன்னு நினைக்கிறேன். சார் தேங்க்யூ சார் தேங்க்யூ.
take questions on the floor. Go to Aruna for a presentation. She is going to, be beyond the office. We'll see what is the working on this direction.
Good morning, everyone. After the scintillating videos by Dr. Veda, probably this topic might be a little boring for you. It's just some interesting cases. So, going directly to the cases, this is Mrs. S. She was 48 years. She was from Coimbatore and she was a homemaker and she was admitted with complaints of very severe headache and inability to sleep since few weeks. She was admitted for that, and headache was holocranial and more of early morning headache, and before it was better during the day. She gets the headache more in the night and in the early morning when she wakes up, and she is not able to sleep because of headache. Fundus shows mild elevated disc margins which was suggestive of raised ICP. Also, patient was seen by ophthalmologist who also confirmed the diagnosis of papilledema. Patient was started on Diamox and NSAIDs for pain. Headache subsided for a few days, but the patient presented with recurrent headache again. So she was a known case of hypothyroidism since 20 years and for post thyroidectomy status on thyroid replacement also. She is a known asthmatic on inhaled steroids, had been treated for seizures for 5 years and was suspected to have autoimmune epilepsy, had been on azathioprine and levetiracetam with steroids. Has had 3 admissions for unconsciousness with suspected seizures since 2012. The neuro team has seen each time for opinion and for unconsciousness. The patient has been ventilated immediately after the admission, twice during which neuro opinion has been obtained. And the patient recovered both the times with steroids and acyclovir along with ventilation and weaning of the ventilatory support. MRA and EEG had been done every time and all these were unremarkable. CSF had also been done which had showed elevated proteins. Patient was discharged with medications for her bronchial asthma along with antiepileptics and steroids. When the steroids were being tapered for the second time, patient had been again admitted with the same complaints of tonic contractions of all 4 limbs, and it was this time that I saw the patient. Again, steroids were already been started and was on ventilator. She was unconscious, then slowly regained consciousness and gradually was weaned off the ventilator. Discharged with an advice to continue steroids. Autoimmune antibody profile at that time was suggested but it was not done due to cost constraints. Hence, steroids were continued. She was already on azathioprine. During the last admission, she was found to have rheumatoid arthritis also, and this time also treated by rheumatologist. Her ENA and ANA profile were done, ANA and ENA profile were done, which were both negative. Due to the disease progression, patient was switched over from azathioprine to methotrexate, and was on, again steroids were continued. They were on a very small, she was on a very small dose on steroid, not much. Steroids were nearly tapered and stopped when she presented again with a severe headache this time, and she was on long-term steroids and also had severe rheumatoid arthritis. So vasculitis was also considered, even though ANA and ANA profile were negative, and we also considered this long-term steroids to be a cause of raised ICP. This was also considered. And so we had to, because she presented with very severe headache and just recurrent with signs of raised ICP, we had to do a diagnostic and a therapeutic LP. All values were normal. After the therapeutic LP, patient's headache was relieved well and she slept well that night. Discharged on the next day because we thought it was only a case of probably idiopathic intracranial hypertension. It couldn't be idiopathic, probably secondary related to steroids. And so since the patient's headache was better, we discharged on the next day. But this time we sent the patient with acetazolamide. Again, she came to us again within 4 days with very severe headache. Fundus showed severe papilledema this time, admitted and started on mannitol. She was admitted in ICU as she was drowsy. CT brain with contrast was done to rule out meningitis at least. She was not able to lie down for a long time, so MRI was not done. This is the CT picture which shows diffuse brain edema. The sulci and gyri had been obliterated with severe brain edema. So we had to give her injection mannitol, and again therapeutic guarded LP was done. But this time lumbar fluid was not under pressure and we were not able to drain more than 5 ml of the fluid. She was desaturating and not maintaining the airway, and she was on NIV that night. She remained drowsy the following day, just answering questions but starting to sleep as soon as we woke her up. We did the ABG as a routine in the ICU, and ABG showed this. This was the thing which clinched the diagnosis. The PCO2 was 111. So she had severe carbon dioxide retention. So NIV was continued and gradually weaned off. Carbon dioxide was gradually coming down and patient remained drowsy on and off. On the 5th day, patient told, "Madam, I have not slept so well like yesterday for the past so many months." And her headache was better on the 5th day. So she was again, but while telling this, she was again falling asleep during the daytime. PCO2 was still on the higher side. She also had a mild stridor. Only that stridor was only obvious at that time. After so many, nearly 6 months of follow-up, the stridor was obvious only during that time. And we got an ENT opinion which showed bilateral abductor cord paresis. Retrospectively, we then considered probably she had an injury to the recurrent laryngeal nerves during thyroidectomy, which was done 20 years back. And from then on, she has had some voice change. After explaining the need and the risk of further speech difficulty, chordotomy was performed. And then a patient PCO2 drastically came down the following days. Was off NIV and for most time of the day, and discharged with the advice to use BiPAP at night and gradually tapering the time of use. Patient came for review. She was sleeping well, doing well, no daytime drowsiness, no sleep difficulty, and no headache. So this was the uncommon point, because she had presented every time, probably with carbon dioxide narcosis secondary to this abductor cord paresis. And every time she came in an unconscious state, nearly unconscious state. She was ventilated. After the ventilator, probably her carbon dioxide settled down and she became all right. We didn't know, none of us noticed the stridor. So stridor was the key point that we were able to diagnose this, and retrospectively asking all the history, getting an ENT opinion, only then we found out that she had probably abductor cord paresis, which is leading on to carbon dioxide narcosis with presentation as raised ICP and papilledema. So patient is now off steroids and antiepileptics and is only on follow-up with the rheumatologist. So coming to the second one, this is Mrs. S. She was 64 years. She was from Coimbatore. She was admitted with complaints of difficulty in walking and slurring of speech with unsteadiness, loss of appetite and urinary urgency. All varied complaints. It was not pertaining to one specific area localization, and she had all these. She was a known hypertensive. She did not have any significant past history. Examination showed bilateral nystagmus, bilateral cerebellar signs. She was not able to stand. There was no pyramidal signs. There was no cranial nerve palsies. So only thing, there was a cerebellar finding. Admitted in the evening and stroke screening was done. There was no cerebellar lesion or an infarct. So no SOL was also seen. Basic investigations were also not informative. So the next day during examination, this was which helped us to clinch the diagnosis. It was just a nystagmus in a patient who didn't have any cerebellar findings nor a brainstem finding. It was not a congenital one. It was new onset and associated with other cerebellar findings. So since the patient did not have any other acute cause of cerebellar disease, I was completing the routine examination, hoping to get some clue. On palpating the abdomen, I could feel a mass in the lower abdomen, and diagnosis was then obvious. Ultrasound abdomen was done immediately, found to have an ovarian mass. Oncologist's opinion was sought, and CT abdomen and biopsy was done and confirmed malignancy. We had already sent a specific paraneoplastic antibody for paraneoplastic cerebellar degeneration associated with ovarian carcinoma. Anti-O, which is the antibody which is specifically present in patients with ovarian carcinoma presenting with the paraneoplastic cerebellar degeneration, and this was positive. Anti-O was positive. Hence, a diagnosis of malignancy was made by its paraneoplastic manifestation. This was the thing which was different in this case. Usually it will be the other way around. Patients will be coming to the oncology, then after getting treatment they will come to us with the paraneoplastic, with the cerebellar, then we will ask for this, but this was another way around. So we thought we'll select this patient for presentation. And the next was Mrs. K. She was 48 years from Coimbatore. She was a homemaker. This patient was referred to me from a scan center following a scan done there for complaints of difficulty in walking and urinary retention. Patient had a trivial RTA following which she had developed a fracture of the 5th metatarsal and was treated outside. She was on POP. She was walking with support following the fracture, during which she noticed numbness of the left lower limb and which was not given much importance as she was already having a fracture. The patient did not give importance. So patient was seen by orthopedician outside and was diagnosed to have lumbar disc. She also had a lumbar disc and was advised rest. Subsequently, she developed a urinary retention for which she was catheterized and again reviewed. Patient went and since the patient's attendant somebody was a doctor, they had got a second opinion from a scan center from where she was referred to me. Patient had at admission, she had paraparesis. She had a sensory level that was below D8 and she had ankle jerks and knee jerks, and she was on urinary catheter when she presented to us. So we considered a possibility of compressive versus non-compressive myelopathy because there was a sensory level, and this was considered and scan was redone because contrast MRI was not done outside, so we wanted to do a contrast MRI which was done. We did not find any evidence of compressive myelopathy or any other intramedullary demyelination as we expected. There was no evidence of multiple myeloma also because the previous scan they gave possibly a multiple myeloma picture was given, but this patient on this scan there was not much evidence of multiple myeloma also in the scan. But even before doing the scan, since we considered multiple myeloma or non-compressive myelopathy like demyelination, we had requested for a bone marrow to rule out multiple myeloma. Bone marrow was done on the second day and was started on steroids immediately after the bone marrow, as there was a strong suspicion of non-compressive myelopathy. Patient started to improve it and started to walk alone on the 4th day. HPE was reported as metastasis. So we had to do a CT screening of the neck, abdomen and thorax to find for the primary and or lymph nodes to rule out Hodgkin's lymphoma or non-Hodgkin's lymphoma. Again, no primary could be found. So PET scan was completed, which also did not show any primary, but bone marrow activity was there, which was suspicious of again lymphoma, leukemia or multiple myeloma. Our bone marrow examination was negative for leukemia and multiple myeloma, and we were waiting for the IHC report. But patient started to improve well. She started walking. She almost became very normal. Only thing we were giving her steroids, and was planned to be discharged when we got this rare diagnosis. The IHC was reported as intravascular diffuse large B-cell lymphoma. This intravascular large B-cell lymphoma is a very rare diagnosis. This was done 2 to 3 years back, and it was a rare antemortem diagnosis at that time. A rare aggressive B-cell lymphoma characterized by proliferation of large B-cells within the vascular lumina alone. Initially, then there will be spread. So skin and CNS involvement is frequent, with the pulmonary, endocrine, hepatic, splenic and bone marrow can also be involved. Patient can present with a fever of unknown origin, can present with neuro or cutaneous signs, unexplained cytopenia, multi-system dysfunction, and usually will have a negative workup. Since this patient was diagnosed early, patient was started on appropriate chemotherapy, and she is doing well. Actually, I was very happy that we didn't give steroids before doing the bone marrow. Had we given one dose of steroids, or anybody else outside given one dose of steroid, we might not have got the diagnosis in this patient. She would have come into the third category, presented with delayed late with multifunction dysfunction, probably later. But she was lucky enough that none of us gave steroids before the diagnosis, and it was diagnosed as a intravascular large B-cell lymphoma, and I'm sure Dr. Sridhar will agree that it's a rare tumor, and patient is doing very well with rituximab and R-CHOP regimen, and she's not on follow-up, she's fine with us. She doesn't have any neurological issues, and she's only on follow-up with a hematologist for her yearly follow-ups. Thank you.
Thank you, madam, for the very nice cases. So before somebody could ask question, I have questions. So that first patient was admitted multiple times.
Yes.
I'm sure IBG would have been done because...
yes, it should have been done, but...
No. Patient went to an ICU many times and in the ER and drowsiness. So...
it was not made out. Probably everybody had thought it is only some carbon dioxide retention, and ventilated. After the ventilator, patient became all right. This was so many times it was done, and only after when I saw, it was the second admission when we were able to pick up and correlate. Actually, we too didn't correlate. Only after I heard the stridor, we correlated. And we got the retrospective history of hypothyroidism. We knew that she was a hypothyroid. She had a scar here. But whether that contributed to the stridor, whether that was the cause, we didn't actually initially think of it. Now she's only on methotrexate.
Okay, so because the many things are odd in that patient. One is you don't see such a PCO2 rise in rheumatoid unless you have a muscle involvement or nerve involvement. And the other thing which we described in neurology looks very odd for a ventilator requirement because he improved after that. Okay, so...
No, that was the reason of presenting this case, because so many times it had been none of us were able to find out. The first episode was not with me, it was in an outside hospital. So later only we had seen the patient. Even when I saw the first time, we had missed. Only the second time when she came with so much of severe cerebral edema, and we had to retrospectively ask everything. Then we asked for an ENT opinion, found an abductor cord paresis. Even while doing the surgery, we were not very sure whether this will give her relief.
Because we see this is the patient is asthmatic. So
Yes.
if you have a type 2 failure with an asthmatic, we tend to think of alternative overlap syndrome. An asthma with an additional hyperventilating disorder. Here it is type 2 failure. And sometimes we see associated cord disorders in this patient. Bilateral also, they don't improve even after the cordectomy or mobilization. So this patient requires a sleep study and followed by a long-term NIV. Regarding the second case, what was the biopsy? The last case, where was the biopsy taken?
Ovarian tumor.
No, the last case, intravascular diffuse large B-cell lymphoma.
Yes.
What was the biopsy? Where was the biopsy, madam? Bone marrow. Okay, no. How to say that is intravascular diffuse large B-cell lymphoma in a bone marrow biopsy?
Gopal has to enlighten.
Because
That was done. It was showing only bone marrow changes, not even infiltrates, changes suspicious of to rule out lymphoma, leukemia, or multiple myeloma. That was what given in the PET.
Because again, intravascular DLBCL getting in a bone marrow is extremely rare diagnosis because it should have been picked up somewhere.
I think this was presented and it was actually published. Only at that time it was done in 2019 or 20 when I was not here. And this at that time there were only some 5 to 7 cases of diffuse large B-cell lymphoma living when we saw the literature. So probably at that time itself it was rare. And
because DLBSL we see often, and how to say it is intravascular diffuse large B-cell lymphoma in a bone marrow biopsy? No, but pathology is microbiological.
No, we didn't do a vessel biopsy. We only did a bone marrow biopsy, which was reported like.
Totally agree with you. Thing is, 2-3 things in this case. First of all, she said non-compressive myelopathy. There is a definite lesion at the level of T8 sensory deficit, and below which everything lost, paraplegia. But see, the most important localizing sign in the spinal cord is sensory. Sensory symptom is there, so something is damaging at the level of T8. But MRI and PET scan, nothing reveals any compression in that area. So we call this non-compressive. If you say non-compressive, then you should have some other cause. But incidentally, B-cell lymphoma can involve the vasculature. That's how we see in the brain multiple cranial palsies because cranials may be thickened and the vascular supply is lost or decreased. Thickening of the cranials, multiple. Likewise, in the spinal cord also, you can have ischemic myelopathy due to vascular involvement and paraparesis. So, since he has proved B-cell and he has proved non-compressive, putting together, we can say probably vascular involvement. But as you said, ultimately we have to do vessel biopsy. Vessel biopsy. That is rather more of academic exercise. Okay, but correlating these two looks like ischemic myelopathy.
My question is fully academic question, sir. The thing is, to say it is vascular, for example, we see pulmonary vascular sarcoma,
Agreed.
pulmonary vascular lymphoma, you need a vessel biopsy. And if you take a bone marrow, and if it is the pathology is DLBSL, is a DLBSL. So we can't say it is intravascular B-cell lymphoma. So that's my thinking. So
yeah, that's it.
Because we don't call intravascular diffuse large B-cell lymphoma, we take a biopsy from them.
But that was how the biopsy was reported.
Yeah, madam. Actually, maybe sometimes
And
the
patient-
bone marrow vessels might have been involved. Maybe in that way.
Probably. And patient became so well after chop.
So which vessel you want to take in this case? Biopsy.
Involved vessels, sir. We don't know.
My question is,
Yeah, we don't know because the PET is not revealing anything. Hopefully, the PET should have revealed something because the DLBCL is aggressive disease. Definitely, the PET should have picked up something because the PET has not picked up anything. Could be just a diffuse marrow uptake itself. Might be involving
Just
the disease.
initial stages probably.
lymphoma can be there with PET negative.
No. Only thing what I would
DLBCL
say
will have
is,
PET positive. Sir. Other lymphomas like follicles, even that will have a.
no, if you want to further extend this, probably you have to go for the spinal angio. Spinal angio, DSA. What I mean is DSA. Spinal DSA. Look at the vessels, radicular arteries, etc. Okay.
Okay, sir. So we'll discuss this of the dice. So we have orthopedic surgeon was
Sir, I
not.
didn't evaluate on that part, sir.
But you were on
Not
leave.
here, sir.
But you were on
Outside.
leave at time. You were leave on
No,
it, not that.
no, it was all this was done outside and then referred. Ortho, all that.
Probably might have been on leave.
No, it was Mohan sir was not.
So we have a. Thank you, madam, for a very nice cases. So over to Dr. Dhivya, madam, for its interesting case beginnings.
So good morning, sir. Good morning to all the seniors and the colleague here. So I'm going to present the challenging cases, what I had operated in my career, and I would like to share the outcome with you all. First of all, I thank you all for giving me this opportunity. It will be a serious talk, like Aruna ma'am. So first is a rare case of a cerebellopontine angle medulloblastoma excision in a 5-year-old child. So medulloblastoma is constitutes about 9.2% of brain tumors in children, and most of them occur in the posterior fossa, especially in the fourth ventricle and the vermis. So the cerebellopontine angle medulloblastoma is reported in less than 50 cases in literature. So most of them are intraaxial tumors. So when the preoperative imaging shows features of medulloblastoma, so the neurosurgeon has to do aggressive surgical resection followed by chemotherapy and then radiation therapy. Why aggressive surgical resection? Because the postoperative risk stratification depends on the residual volume of the tumor. If the residual volume of the tumor is less than 1.5 centimeter square with a negative CS of cytology, the risk is average. But if the tumor volume is more and if there is spinal neuroaxial spread, then the risk is high. So generally, age more than 3 years, no metastasis, average risk, laterally placed tumors in the cerebellar hemisphere, they have a better prognosis. So coming to the child I operated, this is a 5-year-old male child. He presented with 3 weeks history of frequent episodes of vomiting with progressive difficulty in walking. Actually, when he came to the OPD, he was brought like a newborn child. He was unable to hold the neck, he was unable to lift the limbs. So he was conscious, obeying simple commands, and he was unable to take any feeds. So this is the MRI scan. This is the MRI scan, T1-weighted image. This is the right side of the pons, left side of the pons, and right cerebellum, left cerebellum. And this is the hypointense lesion, that is the tumor which was present in the right side of the pons extending into the middle cerebellar peduncle. So this is the T2-weighted image which shows the heterogeneous appearance. So on giving contrast, the lesion was heterogeneously enhancing and the lesion was causing mass effect on the fourth ventricle, but the child did not have any hydrocephalus. So for this kind of tumors, we have to operate. While operating, we use intraoperative neuromonitoring, which helps to prevent the post-operative deficit, especially in brainstem tumors. So I did actually retrosigmoid craniotomy, that is behind, this is the sigmoid sinus. I did the suboccipital craniotomy, went inside. Here actually regular CP angle tumors, we cannot act, if we do like a regular CP angle tumor going in front of the cerebellum, it will be difficult to reach the tumor and we will produce a lot of deficits. So what I did, I went through the petrosal fissure. That is on the medial surface of the cerebellum, we have a fissure here, it's not so obvious here. So which separates the cerebral hemisphere medial surface into upper quadrant and the lower quadrant. So if we open the petrosal fissure, actually we can directly reach the middle cerebellar peduncle. So we can start removing the tumor. Middle cerebellar peduncle approach is a safe approach to brainstem tumor excision. So the surgery was done and we remove the tumor until we see the normal brain tissue all around. So I didn't use intraoperative monitoring, but I just went with the vision, like the tumor was actually pinkish vascular. So how much ever of the tumor I could remove, I removed until I saw the normal brain tissue. So this is the post-operative CT scan. I was able to achieve gross total resection of the tumor, and this is a post-op CT showing the tumor excision cavity with the hemostatic agent, and did really well. Actually, he was extubated on the first post-operative day after the CT scan. He was shifted to ward and started on oral feeds, and he was able to tolerate it on the second day itself. And he was discharged on the fourth post-operative day with neck holding. And this is a 10th post-operative day video, and he was able to walk without support. And he was having a normal gaze, and the histopathology came out as medulloblastoma and desmoplastic variant, but the MIB labeling index was very high, 70 to 80%. He was referred for chemotherapy and radiation therapy. That was one of the satisfying results I had. And the second case is a left CP angle vestibular schwannoma. When in vestibular schwannoma, a neurosurgeon's challenge is to preserve the facial nerve and if possible the auditory nerve, the hearing. And of course we should avoid injuring the lower cranial nerves to avoid the post-operative morbidity. So 22-year-old male presented with the left ear hard of hearing for 3 to 4 years, and he had involvement of the fifth cranial nerve and grade 2 weakness of the facial nerve, and he had cerebellar symptoms and signs with features of raised ICP, that is headache, bilateral 6 nerve weakness. So this is the imaging MRI brain T2 weighted image, which shows again a large CP angle extraaxial tumor, heterogeneous lesion causing mass effect on the cerebellum, middle cerebellar peduncle. This is the pons, and we can see the fourth ventricle is compressed. We can see the basilar, this small dot, that is the basilar artery. This is the 7th-8th internal auditory canal where the 7th-8th nerve passes. So the tumor was extending into the internal auditory canal. So diagnosis was actually acoustic schwannoma, means vestibular schwannoma. So patient had hydrocephalus, and with contrast the lesion was heterogeneously enhancing. So again, like the patient underwent retrosigmoid craniotomy. I removed the bone here in the posterior fossa, went inside and removed the tumor. Again here, so if we go through this, we have to retract the cerebellum so much to reach this portion of the tumor. So here we can see the petersal fissure here on the opposite side. So in this side, the petersal fissure was opened, and then we can easily reach this tumor, and it helps to achieve a better surgical resection without retracting or resecting the cerebellum. So in this patient I used intraoperative neuromonitoring, 7th cranial nerve and 5th cranial nerve neuromonitoring was done, and while resecting the tumor near the system, means along the facial nerve, actually there was drop in facial MEP, so little bit of tumor was left on the cysternal portion of the facial nerve. And I put EVD for this case during the surgical resection. And this is the first day post-operative scan, which shows the surgical resection cavity. And patient was extubated on the first post-operative day. 6th cranial weakness was completely resolved, and he had grade 2 facial weakness, which was present pre-op. There was no further deficit. And luckily, this patient actually had hearing preservation. So he had severe sensorineural hearing loss, but it was preserved. Actually, there was slight improvement also. So here after 3 months when he came, there was no facial weakness, and this is the 3 months post-op MRI with contrast, which shows small lesion enhancing at the facial nerve cysternal portion. So this was one of the good outcomes, like facial nerve preservation and some auditory preservation I had. So next case is an arteriovenous malformation resection. So this is one of my dream surgeries because it's very challenging, one of the very challenging neurosurgical procedure. So 21-year-old male presented with sudden onset of headache with no neurological deficit. So he had this headache 20 days before. He was from Bangladesh. So he came to me, like the CT was done, and it showed a right parieto-occipital large subacute hematoma, and young age with a spontaneous bleed. We have to suspect vascular malformations, and AVM is the first differential diagnosis. So this is the MRI brain, which shows abnormal leash of vessels with a prominent vessel here suggestive of AVM, and cerebral angiogram was done that also showed a nidus, AVM nidus with underlying hematoma. This is the cerebral DSA done, and this is the right ICA, MCA branches were seen supplying the AVM. This is a posterior circulation DSA, like a veritable DSA, so which shows posterior branches from the posterior cerebral artery supplying the AVM nidus, and the AVM nidus was draining into the superior sagittal sinus, the transverse sinus. So we do supplementary Spitzer-Martin score. If it is 6 or less than 6, that means the operative risk, post-operative risk is lesser. So I took the patient for surgery. So in AVM resection, we have to follow certain rules. We should, like a tumor, we go inside, decompress the tumor and remove the other portion. But here in AVM, we should never get into the AVM at all. We should go along the gliotic plane around the tumor, and then we have to coagulate the arteries first and leave the large draining vein till the end of the surgery. Otherwise, it will be difficult to remove the AVM. So, and we should not leave any residual AVM, otherwise the patient will develop post-operative bleed. So this is the AVM, like on the surface, this is the abnormal lesion of vessels, and this is the largest draining vein which has to be preserved till the end of the surgery, and this is the MCA feeder which was supplying the AVM. So the surgery was performed, and the patient was extubated on the same day. He did not have any neurological deficit, and we have to post-operatively we have to prevent any normal pressure breakthrough bleeding post-operatively. That is very important. We have to maintain normal blood pressure. That was maintained, and he did not have any bleed, post-operative bleed. This is the first POD scan, CT scan, that does not show any nidus, and this is one of the MCA vessel feeder which is looking more prominent. He was discharged on the 5th post-operative day, and this is a CT cerebral angiogram was done after 3 months follow-up, and the prominent vessel which was seen in the immediate post-op, that was also not seen in the 3 months follow-up CT, and the patient really did well, and this was one of the satisfying results I had, and this is one rare case I would like to present, a superior semicircular canal dehiscence syndrome, which is a rare case, and it was first described in 1998. So the patient presents with sound or pressure induced vertigo. If they hear loud sound, they will develop vertigo. So why? We have no oval window and round window, but these patients will have a third window. That is, the bone over the superior semicircular canal is dehiscent, which communicates directly with the middle cranial fossa. So they have a third window. So the patients develop with vertigo, oscillopsia induced by loud sounds, and Valsalva maneuver, which is called Chelios phenomena, and they have other features like autophony, hyperacusis, and all those things. So pure tone audiogram shows low frequency conductive hearing loss, cervical, vestibular evoked myogenic potential shows lesser threshold, and however we have to do high resolution CT temporal bone to confirm the diagnosis. So for minor symptoms, we give medical treatment. For debilitating symptoms, surgical treatment is the option. So this is very rare to diagnose. The patient actually was diagnosed by the ENT surgeon and referred to me. This 41-year gentleman, he presented with this vertigo. So for 5 years he was going to multiple hospitals, and then slowly he was unable to pursue his work. So he quit his job, and finally he was unable to do his routine activities because of the vertigo. So he came to the ENT surgeon. So the tests were confirming the superior semicircular canal dehiscence. HRCT of the temporal bone was done. This is a special view done, that is called the Puschel's view. So this is the bone window, temporal bone window of the CT and temporal bone. This is the middle cranial fossa, and this is the lateral semicircular canal. This is a superior semicircular canal, and we can see that there is no bone over the superior semicircular canal. So since he had debilitating symptoms, surgery was planned. So actually ideal treatment for this condition is we have to plug the superior semicircular canal and resurface the bony defect. So this can be achieved by middle cranial fossa approach by a neurosurgeon. So hence he referred the patient to me. So we proceeded with the temporal craniotomy. So patient was in supine position, head was rotated, and the temporal craniotomy was done. So this is the dura, this is the temporal bone. So I went extradural, and this is anterior, this is posterior. So here we can see a small defect, that is the roof of the bony defect over the superior semicircular canal. So that was filled with the bone dust, or we can put free fat graft also. So and then there was another defect found anteriorly, that was also filled with the bone dust, and then we have to place the facial eta. Actually this is the facial eta. So and I put the facial eta and then fibrin glue. So patient had actually 70% improvement in his vertigo, and this is a post-operative scan showing the superior semicircular canal filled with the bone dust. So this was one of the interesting cases and rare cases. So I like to present, and thank you all for the patient listening. Thank you. Thank you. Thank you.
What will you do for the residual tumor over the facial?
So we observe the patient, we repeat the scan after 6 months. If there is any increase in the size of the tumor, then we can refer the patient for radiation therapy. So that really helps to control the growth of the tumor.
So his question is bone dust.
So when we perform craniotomy, actually we get bone dust, the small dust of bone that we can keep inside. Sir, yes, sir, over time, if maybe after 4-5 years, if you repeat the scan, actually it fuses, sir. Sir, if it grows, yes, sir, we give radiation therapy, sir. So we remove the tumor, we leave a small residual tumor. If on regular follow-up, if the tumor actually grows in size, one thing we can go ahead, redo the surgery, or we can directly give radiation therapy. Now there are so many advancements in radiotherapy. Actually they do well, sir. I have seen patients, small lesion, recurrence. So we give radiation therapy, they have very good control. We leave the tumor to preserve the facial now. So otherwise if we try to remove the tumor, it will be gone, sir. So patient will be, lifetime he will be with the facial weakness. So this one helps, sir, actually.
Thank you, madam. But he can also have radiation-induced neuritis later.
Sir, radiation oncologist has to answer, sir. But actually they don't develop, sir. I have seen.
No, that's so still you can treat them with the steroids. Sir, this is related to neurosurgery. So.
Third case is very interesting case. It is a very rare case only. I think I have not seen such surgeries for vertigo.
Dr. Dhivya have done a very good, fantastic job.
Thank
because
you,
large sleeping angle tumors, removing the tumor, it's really very difficult to preserve the facial now. Ultimately, they end up with the facial palsy and things like that. And most satisfying, you could remove or you can extubate on the same day.
Yes.
That's very important. The earlier the extubate, probably the outcome is good. And if you cannot extubate in another 2-3 days, the patient is going to have some other problem. And they'll get into more and more problems. So all these cases, you extubate on the same day.
Means next day, sir. First POD.
Yes, sir.
Yes, sir. Within less than 24 hours, yes, sir.
First POD, whatever it may be. That's very satisfying. And the results are good.
Yes.
And AVM, you said AVM. The only thing is AVM, first time diagnosing AVM with a large hematoma. You do removal of the hematoma and
excise the AVMs. Sir, if it is...
How about removing the hematoma and embolizing the AVM?
AVM embolization, sir. Sir, AVM embolization, actually it is not the definite treatment, sir. First, to help the surgical management, we do the embolization, sir. But it is very risky.
Okay.
So in neurosurgery, embolization for AVM, embolization actually doesn't have a definite role, sir. It helps in radiation therapy or it helps before the surgery. We do embolization, we operate within 2-3 days. Yes, sir, it helps to reduce the bleeding. That's all, sir.
Probably you could resect it out totally.
Better, bleeding will be lesser, it will be easier, sir. Yes, sir.
No. Do you suggest that embolization and resection? Or straight away going to resection?
Sir, it depends on the size of the lesion, sir.
I'm asking about large AVMs.
So larger AVMs, actually we can give embolization and then we can go for surgery. But the problem is the money, sir. And it should be available. So actually I have operated only 2 cases. One is your patient, sir, and this is my first case. So it's not that easy to get the AVM cases. And but yes, the money is a limiting problem. For this patient, I think no need for embolization, sir. This is a small AVM.
Yeah, to be very frank with you, my case that a Muslim patient who had operated, he is doing very well. A large AVM, he is middle-aged, 45 something.
Is it 39, 40 something?
40. Large AVM with bleed, with large hematoma. She did a very good job. And I thought he will not survive. But no, middle syndrome. I don't
Mustafa, sir. Mustafa.
Some name. and she is hale and healthy, walking around. Is doing well.
Thank you, sir. Thank you, sir.
Thank you.
Coming to the clasping of the hands behind, we can see, as Dr. Asokan rightly pointed out, it is mostly seen in the elderly. When you become a unit chief in government hospital, most of the chiefs can be seen to walk like that. This is a tendency, Sarve sir, please excuse me, inherited from African apes. We used to have this Margagnis hernia, protrusion of intestine just behind the sternum. This race of apes used to have the condition quite often, very high incidence. Those apes have been found to walk with the hands folded behind. So we have probably inherited it from those apes. Thank you. And the confidence. And now I should watch whether it's
Thank you.